So dear postgraduates, last class we discussed about the rheumatoid arthritis. So what is the definition of the rheumatoid arthritis and the different causes for the rheumatoid arthritis, how to diagnose it, your EDA classification, etc. And finally, we stopped before the management part. So this class we will finish the management of the rheumatoid arthritis. So by this time you all know that rheumatoid arthritis is a very important arthritis as far as the connective tissue disorders are concerned. Unfortunately, many women in India are having with this, are suffering with this rheumatoid arthritis. Unfortunately, it occurs in their prime age group, between 20 to 40 years of the age group. Sometimes it is very difficult to diagnose the rheumatoid arthritis in the initial days. Most of the times they were treated by the RMPs or the the pharmacy management and etc. And finally they get the diagnosis of the rheumatoid arthritis. It was so late. So the late presentation of the rheumatoid arthritis obviously will lead to the lot of the morbidity and the mortality, and also they will have a severe articular and also extra-articular manifestations. Even today we are seeing a lot of the rheumatoid arthritis patients with ILD, with hepatic abnormalities, with the renal abnormalities, and also hematological abnormalities and etc. And ultimately, lot of the rheumatoid arthritis individuals in India, they are living with poor quality of the life. So as a good physician, we should aim for early diagnosis of the rheumatoid arthritis, and we have to improve the quality of the life in all the rheumatoid arthritis individuals by your proper management. So in that aspect, this class is going to be one of the very important class, because today we are going to deal the management of the rheumatoid arthritis. When and why? So when to treat? The treatment should be started very early and it should be individualized. So don't wait to initiate the appropriate medications for your rheumatoid arthritis. Not your NSAIDs or your appropriate treatment management. That is only the painkillers and they are only symptomatic. So our aim is to give an early aggressive management with your disease modifying rheumatology drugs, and the patient can afford, and if needed, even the biologicals also the day one of the diagnosis of the rheumatoid arthritis. So you should focus on relieving the pain, prevent the damage and the disability. That is very important. Patient education is also very important about the disease, because this is a chronic disease and it is a progressive disease and it is an aggressive disease and it is a relapsing disease. So these you should discuss about this disease with your own patients. And physical therapy for stretching and the range of the motion exercises. The physiotherapy also will help a lot in all the rheumatological conditions. We give a lot of respect to the physiotherapists, because without their role, so the total management of the rheumatoid arthritis is not right. Sometimes an occupational therapy for the splints and adaptive devices. Sometimes the surgery also plays a major role in this rheumatoid arthritis, but don't involve the surgeons. If you involve the surgeons, means the disease is already very much damaged and the people with a lot of the disabilities. So our aim is diagnose early and treat early and aggressive management. So ultimate part in the management of the in the rheumatoid arthritis is the inflammation. So the inflammation in the synovial membrane, that is the synovitis, and there will be synovial effusions and there will be the damage of these major joints. So the fundamental concept of the rheumatoid arthritis treatment is, so obviously the detect and the refer to a physician. So not to the general practitioner or to the orthopedic surgeons. So the treat immediately. So it's very important. Don't wait. Even for the investigations also, once your diagnosis is rheumatoid arthritis clinically, already I told you the 7 criteria, 4 out of the 7 criteria. So almost the 5 criteria are the clinical criteria, are the symptomatics. And then tailor the treatment to the individualized. So it depends on the management, depends on the individual. Suppose if the fellow is pregnant, so definitely our hands are very tight in using the leflunomide and also the methotrexate, and you can safely use the hydroxychloroquine. Suppose if the person is having the rheumatoid lung, so that means that is mostly either because of your interstitial lung disease or sometimes it could be because of your methotrexate therapy. So in such situations, that lung is because of the methotrexate side effects, and definitely have to stop using the methotrexate. So the treatment must be individualized. There are only few drugs in our hand, but these drugs you should be very useful, carefully combine these drugs, because nowadays again in rheumatoid arthritis, a combination therapy is the rule today. Like your hypertension management, or your tuberculosis management, or your HIV management, or your diabetes management, the combination drugs therapy is very, very important even for the rheumatoid arthritis also. So don't be happy with only lefuronamide, or only methotrexate, or only hydroxychloroquine, or only sulfasalazine. Sometimes these people, they may require 2 drugs or the 3 drugs, sometimes even the 4 drugs also. So the combination of the drugs is also very important to address your inflammation at the synovial level. So why to treat early? Because it is a progressive and an aggressive disease and leads to a lot of the inflammation. See the inflammation. Inflammation is very high in the initial few years, and after 20 years or 25 years of the higher rheumatoid arthritis life, the inflammation may not be that high. But what is more important here is a disability and also your radiological changes. Again, in the early days of the rheumatoid arthritis, you don't have any radiological changes. Radiological changes occurs much later. But the disability and the inflammation is very, very important. So that is the reason we have to treat all the rheumatoid arthritis individuals to avoid a chronic inflammation, chronic disability, and also to reduce the radiographic changes. Why the structural damage is very important? Because of it reflects the disease control. Suppose if the person is having a lot of the disease activities, so obviously our structures in the hands, or the structures in the foot, or the structures in the knee joints, or other joints, any other joints which involves here, but mostly the spine will be spared here in the rheumatoid arthritis, unlike your ankylosing spondylitis. Surrogate marker for the long-term outcome, the physical function and employment. In stable disease activity, very slow increase in the HAQ score and constant progression of the structural damage. Non-pharmacological management is also very important. So here the diet plays a major role. Exercise is always very, very important. Acupuncture, in some individuals, especially the China, they depend more on the acupuncture. Herbal medicines, again some countries, again China, they depend more on the herbal medications. Even our areas in Rampachodavaram and tribal areas, so they depend more on the herbal medicines. And massage, so that is also useful in some cases. And stress reduction techniques like your prayers, meditations, hypnosis and yoga. So these are all, because any chronic disease, so using the drugs for the longer period is not possible for the lower middle class or the poor individuals. So they have to buy from their pocket. So then definitely they opt for your acupunctures or herbal medicines or prayers or churches or masjids or Tirupati or meditations, etc. These are very cheap techniques. So obviously the poor people, there are always a tendency to fall on these reasons. But for us, I think the more important is our DMRDs only. The nutrition, these are all the very, very important. So not only for rheumatoid arthritis, for any chronic disease, the folic acid is very good, vitamin C, good, lemon, etc. Vitamin D is also very good. Nowadays 80% of our Indians are vitamin D deficient or insufficient. Vitamin B6, B12, especially it is very much reduced in the chronic metformin therapy and also chronic ethanolics. Vitamin E deficiency, calcium deficiency, magnesium, zinc, selenium. So these are all very much deficient in the malnourished individuals, in elderly individuals, in diabetic individuals, the individuals on steroid therapy, or the individuals on the immunosuppressive drugs or oncology drugs, etc. So definitely these are all very much needed as a supplements in some individuals, not in all individuals. Don't prescribe all these drugs for each and every diabetic or rheumatoid arthritis or hypertensive. Only few people they may require it. Exercise is also very important. Being overweight strains the joints and leads to the further inflammation. So obesity is always dangerous. More the obese, so obviously you have the lot of the diseases associated with the obesity, and one out of them is the degenerative arthritis. So that is your osteoarthritis. So in rheumatoid arthritis, osteoarthritis also comes much earlier. Suppose if you take the two people, one fellow with rheumatoid arthritis, other fellow with third rheumatoid arthritis, so the fellow with rheumatoid arthritis may get osteoarthritis 1 to 2 decades earlier when compared to the non-rheumatology patient. So definitely exercise will play a major role, not 4 times a week for 30 minutes, maybe 7 times a week for about 50 to 60 minutes. So either walking, light jogging, water aerobics, cycling, yoga, tai chi, that is again the China exercise, and stretching exercises. So the diet, the weight loss is very important if you are overweight or the obese. So BMI 23 is the upper normal for us. More than the 23 we are overweight. So 23 to 25, more than 25 is the obese. Whereas the Western population up to 25 is the normal, 25 to 30 is the overweight, more than 30 is the obese. So for us, so visceral adiposity is very, very common. For a given BMI, you are having the more fat. So that is the reason BMI levels have reduced them. But still, we don't prefer the BMI for Indians, but what is more important rather than the BMI is the waist circumference. So waist circumference more than 80 centimeters in the females and more than 90 centimeters in the males are the obese, and waist hip ratio more than 0.9 in the females and more than 1 in the males is again the obese. And you can also calculate the skin fold thickness to define a person is obese or not. So there are the 4 values, either the BMI or waist circumference, waist hip ratio or skin fold thickness. Out of them, the Western population, they depend more on the BMI, whereas the Indians, better out of these 4 is the waist circumference. So antioxidants are very, very important for any disease, any chronic disease like in rheumatoid arthritis. Vitamin C also helps, and some supplements. So exercises, so always the swimming is the best exercise next to the, swimming is the best exercise. After that, it may be brisk walking is also good, the physical therapy and yoga. What are our goals of the management? Focused on relieving the pain, prevent the disease, decent education, physical therapy, see the early and aggressive treatment. Already discussed about this slide. So treatment should be started much early, that is very, very important, not early, much early, and should be individualized. So there are the 4 types of the medications used to treat the rheumatoid arthritis. They are the NSAIDs, so our favorite drugs for all Indians, DMRDs. So even a physician, we are not confident of writing the DMRD. Sometimes I've seen the prescriptions from a qualified physician with MD general medicine, but still the DMRD therapy is not up to the mark. So how to improve the DMRD therapy in all the rheumatoid arthritis individuals. Steroids are the excellent drugs, not for the long term. So how to use the steroids as a bridge therapy for the initial 6 weeks or the 8 weeks. And of course, the game changer here is the biologicals. Even though the movie Game Changer was a big flop, but this game changer biologics are very great hit in rheumatoid arthritis. What are the treatment modalities here? So NSAIDs, good. Steroids, very good. DMRDs, very, very good. Immunosuppressive therapy, excellent. Biologicals, super. And surgery, flop. Don't expect the surgery in all rheumatoid arthritis. So if your patient is going for the surgery, that shows your inefficiency in treating the rheumatoid arthritis. Okay? But if the fellow is definitely crippled, and definitely the surgery is also needed there. Maybe the knee replacement, maybe the hip replacement, maybe the shoulder replacement, etc. So the replacement therapies are very much needed in these individuals. I have one patient who got bilateral hip replacement, bilateral knee replacement, and also one shoulder replacement with rheumatoid arthritis, early osteoarthritis. So these are the NSAIDs. You are all agree with me. So a lot of the drugs are there. Your aspirin, your brufen, your diclofenac, your naproxen, your phenyl acetic acids, etc. Ketorolac, indomethacin. So these are all the common drugs. We are Eterolac, celecoxib. So these are all the different NSAIDs we often use. They are anti-inflammatory. Sorry. They are antipyretic and also analgesic. So analgesic, the control the mild to the moderate pain. Antipyretic, so some people they may have the fever along with this when the fellow is in exacerbations or in spikes of the rheumatoid arthritis. So as it is an inflammatory disease, so maybe 99, 100, 101 is also very common. There you can use these paracetamol, etc. And the anti-inflammatory is a very, very important, used in the management of the inflammatory. So rheumatoid arthritis is a big anti-inflammatory disease. What is more important is the side effects. So side effects are very, very important in NSAID therapy. Some people may develop the nausea, vomiting, especially the smokers and the alcoholics. And people who are taking the multiple comorbidities, so obviously the drugs using are also very high. So few diabetic drugs, few hypertensive drugs, etc. So obviously the drug-induced gastritis is also very common along with these NSAIDs. Some people, they will develop the diarrhea, constipation, dizziness, drowsiness, edema because of the NSAIDs, kidney failure, so acute interstitial nephritis following your NSAID therapy, so liver failure, maybe paracetamol overtoxicity, etc. and prolonged bleeding and ulcers in the stomach or in the esophagus or in the duodenum, so etc. See the side effects profile. So one should respect these side effects when the fellow is in the chronic NSAID therapy. So chronic NSAID therapy, present with nausea, with vomiting, with diarrhea, constipation, dizziness, drowsiness, edema, kidney failure, liver failure, prolonged bleeding, and different ulcers in the gut. So what are our considerations? So use cautiously in patients with the treatment with the bleeding disorders. So don't use the NSAIDs in higher dosages in the people with the bleeding disorders. Encourage the patient to avoid the concurrent use of the alcohol and the smoking. So don't advise the alcoholism and the smoking when the fellow is on the chronic NSAID therapy. NSAIDs may decrease the response to the diuretics or the antihypertensive therapy. So they reduce the pain and swelling by inhibiting the COX. We have the COX-1 and the COX-2 inhibitors. They don't alter the course of the disease. That is the most take-home point. Whatever the tons of the NSAIDs you give, they are only symptomatic. So they don't arrest the disease or they don't stop the progression of the disease. So don't give much credit to the NSAID therapy as far as the progression of the rheumatoid arthritis is concerned. So our aim is to reduce the disease activity also. So they don't alter the course of the disease. So they should be used only as and when required, only SOS basis. Chronic use should be minimized because of the lot of the side effects, especially your renal failure, maybe hepatic failure, your gastritis, etc. Most common side effect is related to the GI tract. Steroids are the excellent drugs, but don't use it for the longer period as a bridge therapy. So you have the cortisone, hydrocortisone, prednisone, betamethasone and dexamethasone. So these are all the different types of your steroids available. So mostly we use the prednisolone. Your Visalone, maybe 5 milligrams, maybe 2.5 milligrams, 10 milligrams, 20 milligrams, 40 milligrams, 60 milligrams, sometimes 1 milligram per kg body weight, all for a very shortest period only. Very short period. So before, first you have to start with the DMRDs. DMRDs will take the longer time for its therapeutic action. Some people, sometimes it may go up to the 2 to 4 months also to have your therapeutic advantages. So meanwhile, you can use these steroids. So that is called as the bridge therapy. So always stop it. But most of our patients, if you don't tell to the patient that I am starting the steroids, you will be very comfortable. But definitely after 2 months or the 3 months, the steroids has to be reduced. Otherwise, no, all these people will be very happy with the steroids. Some of my patients, they took only steroids only because they are the cheap, available everywhere, and they are very potent, and they are very comfortable as far as the pain reduction is concerned. But they don't, again, these may not alter the disease progression. So that is the reason you have to tell before you start steroid therapy to our patient that these drugs has to be stopped after 2 to 3 months of your DMRD therapy. So used in the management of the inflammatory, lot of the conditions where we use the steroids. So dermatological conditions, chronic urticaria, eczema, etc. we use it. In ophthalmology conditions, they use the steroids. In our internal medicine, so respiratory, yes, bronchial asthma, etc. Again in the gastrointestinal, yes, in your ulcerative colitis and Crohn's disease, inflammatory bowel diseases. So definitely, suppose again in the renal, yes, in the nephrotic syndromes we use a very high amount of the steroids. So name any organ, any system, so there is a role of the steroids, but these are the double-edged weapons. So one should be very careful. When NSAIDs may be contraindicated, promptly improve the symptoms of the rheumatoid arthritis. What are the side effects? Again, the lot of the side effects are there. Increases the body weight, increases your sugars, increases your blood pressure, increases your lipids, and disturbs the sleep, etc. And of course, the weight gain is also very, very important. So increased appetite, weight gain, water and salt retention, obese, edematous, increases the blood pressure, thinning of the skin, depression, the mood swings, muscle weakness, osteoporosis is very common in the postmenopausal women on the steroid therapy. So you should always combine with the Shalcal, not the 500 milligrams, at least 1000 milligrams. Delayed wound healing is also very common with the steroid therapy, and onset and the worsening of the diabetes. If the person is a known diabetic, so control is very, very poor. The sugars will be very high in the presence of the steroids. And suppose if the person is at risk of getting the diabetes with a strong family history and obesity, and definitely you are inviting the diabetes in using the steroids for a longer period. So they take medicines as directed. So SOS basis only, used with the caution the diabetic patients because the control will be very poor. Encourage the diet high in the protein, calcium, potassium, and the low in the sodium and the carbohydrate. So the more fruits, more calcium is very much needed for the people who are on the steroid therapy to avoid osteoporosis. Discuss the body image. So definitely the image will be changed with the good steroid therapy, striae, etc. And discuss the risk for the infection. So steroid therapy definitely invites a lot of the infections. The people on the steroid therapy, so there are high chances of getting the viral infections, pneumococcal infections, and also tuberculosis, etc. Both systemic and the intra-articular rheumatoid arthritis, who use the steroids in the rheumatoid arthritis in the two ways, three ways in fact. One is the oral, second one is the injectable when the fellow is in the crisis, and the third are in vasculitis. So we use the Solumetrol 500 milligrams or 1000 milligrams once a day for at least 3 to 5 days or 6 days. So that is how we have to use in the crisis or in the vasculitis. Otherwise we use the oral prednisolone, your Vicodin, and sometimes we have to give the intra-articular steroid also. So intra-articular prednisolone is also, methylprednisolone is also available, 40 milligrams and 80 milligrams. So that can be given even intra-articular, sometimes it may be intramuscular also. So all the three forms we use routinely in our routine practice as per the steroids are concerned. So 80% we give the oral prednisolone, sometimes we give the injectable prednisolone IV, and sometimes we give the low dose of the prednisolone maybe once in a week or once in a 15 days or once in a month intramuscularly. And when the disease, when the joint is very much inflamed and there is a lot of the synovitis or the synovial effusions, even the intra-articular steroid also we have to give it. What are the indications? For the treatment of the rheumatoid flares, ups. So the disease is very aggressive, flare means very aggressive, use the steroids, bet the steroid. For extra-articular rheumatoid arthritis, vasculitis, interstitial lung disease, so the steroids are very much needed. As bridge therapy for 6 to 8 weeks before the action of the DMRDs begin. Maintenance dose of 10 milligrams or less of the prednisolone daily in the patients with active rheumatoid arthritis. Sometimes in the pregnancy when other DMRDs cannot be used. So in the pregnancy, the two drugs are very much useful. One is the hydroxychloroquine, the second one is steroid. Steroids can be safely used in the pregnancy. So these are all the advantages of the steroid therapy. Very good drugs, very, very good drugs. But be careful. As a physician, you should know when to start a steroid. Anyone can start steroid therapy. But as a good physician, you should know when to halt the steroid therapy. When to start, reduce the dose of the steroid therapy. That is the very important. How is rheumatoid arthritis treated? Most patients will require a disease-modifying anti-rheumatic drugs. That is the very important. From your pen tomorrow onwards, for every rheumatoid arthritis patient, there should be some 1 or 2 or 3 DMRDs in your prescription. Maybe steroids for as a bridge therapy. Maybe NSAIDs, SYS basis. But they must be on DMRDs for quite a long period. How long? Maybe lifelong. Maybe lifelong. Okay, rheumatoid arthritis is a chronic disease like your IHD or CKD or diabetes or hypertension. So don't expect 1 year therapy or 2 years therapy or 6 months therapy in a rheumatoid arthritis. Maybe lifelong. Now the immunosuppressive drugs, methotrexate, most effective single DMRD. All over the world, the most effective DMRD, the number 1 DMRD in the rheumatoid arthritis therapy is methotrexate. So big thanks to Yella Pragata Subbarao garu who invented this methotrexate. Good benefit to the risk ratio, but you should give as a pulse therapy only. Don't give every day. So they will cause a lot of the bone marrow suppression, hepatitis, renal failure, etc. etc. It's again a methotrexate is a double-edged drug. Okay, on one hand it is very useful, on the other hand very harmful. So useful when you use the pulse therapy. So once in a week you may start with 7.5 milligrams or 10 milligrams, 15 milligrams, 20 milligrams or 25 milligrams. And you also have a oral forms. 95% we use the oral, available in the oral form methotrexate. Sometimes we give the injectable one also. Some people they have some nausea and vomitings with the oral therapy. Then we will choose the intramuscularly. Okay, it is available 15 milligrams per 1 ml or 25 milligrams per ml. So a good benefit to the risk ratio. Yes, every drug will have some risk. In the same way, methotrexate also will have some risk. But if you see the benefit of your control of the inflammation, or reducing your synovitis, or avoiding your disabilities, deformities, so definitely the benefit is much more than the risk. See, statins therapy, they may cause new diabetes. Statin therapy may cause new diabetes. But what is the benefit? Excellent benefit, reducing the lipids and also pleiotropic effects. So that is the reason. So don't bother about the new onset of the diabetes and the statin therapy. The benefits are very, very high. So in that way, again the methotrexate, the benefit is very, very high. Azathioprine, yes, available in 25 mg and 50 mg. So we use it azathioprine when in extra-articular rheumatoid arthritis. As long as the patient is articular rheumatoid arthritis, we choose these DMRDs. When the fellow is also having extra-articular rheumatoid arthritis, maybe your hepatic involvement or the lung involvement or interstitial lung disease, so we add azathioprine also. Azadar is available 50 milligrams and 100 milligrams or 25 milligrams. We start BD and slowly we can uptitrate the dose. Cyclophosphamide, yes, we use it again as a cycle, as a pulse therapy. Cyclophosphamide 1 gram 1000 mg. So once a day for about 5 to 7 days, especially in the vasculitis individuals and in interstitial lung disease individuals. When the disease is in the flare and the patient is very sick, they need very potent immunosuppressive drugs, then we vote for the cyclophosphamide. Cyclosporine, yes, available as the oral form. So that is superior to the placebo, but the thing is, it has some renal toxicity. So when the creatinine level is higher, when the hypertension is very high, so we don't prefer to use cyclosporine because cyclosporine may cause renal toxicity and also induces the high blood pressure. So the triple drugs, first one, the second one is the sulfasalazine and hydroxychloroquine, 2 drugs therapy, and the third one is the monotherapy, so methotrexate. See the percentage with the 50% ACR response. So which one is having the more response? Nearly 80% response with monotherapy or triple therapy. So this slide clearly shows you the triple drug therapy is very much useful in the management of rheumatoid arthritis. Superior to any one or 2 alone for ACR 50% improvement response and maintenance of the response. Side effects, no greater. So don't bother about the side effects of these multiple drugs. Every drug will have the few side effects. For example, methotrexate. It's a very potent drug. And what is important is some of my patients know, if you said once in a week, if they don't reduce the, if they are still having the much and pains, they thought that this is also one of the NASIAD and keep on taking every day. So that will be definitely very unfortunate thing. So one fellow, they present with aplastic anemia. Okay, leukopenia, pancytopenia, etc. So it's very important. So we should tell to the patient, you have to tell it, and again will be by your assistant, maybe your senior sister or your receptionist. These are very important take-home messages. Not only the uneducated people, even the educated people also. So they don't know the side effects of the methotrexate and sulfasalazine. So these are the very important. But usually in the rheumatoid arthritis, we don't prefer much of the sulfasalazine. So our favorite DMRDs in rheumatoid arthritis are methotrexate, leflunomide. Methotrexate and leflunomide, and of course hydroxychloroquine, especially in the females, in the pregnant females, etc. So the triple drug therapy, 77% get the 50% improvement. Methotrexate, single drug, 33%. Double drugs, you have the 40%. Plaquenil is nothing but your hydroxychloroquine, okay, plus sulfasalazine, maybe 40%. Methotrexate alone, about 33%, and the triple drugs, 77. So this clearly shows you the importance of the triple drug therapy in an established rheumatoid arthritis individual. Anti-TNF medicines have revolutionized the treatment for the rheumatoid arthritis. So this is the premier data. They are encouraging because they suggest that early and aggressive treatment may slow or inhibit the patient's joint damage. So that's a very important point. So our aim is to reduce the speed of the progression. So that means slowness of the disease, or sometimes we have to inhibit the patient's joint damage. That is very important, inhibition. So both can be done by using these biological drugs. They got the Nobel Prize for the discovery of these biologicals. Who got the Nobel Prize at the youngest age? Youngest age, Nobel Prize. Anyone? Our specialty, my favorite subject. Nobel Prize given to the Banting and his professor, MacLeod's. HOD, MacLeod's. Under him, Banting is working. So the Nobel Prize was given to the Banting and the MacLeod's. And Banting shared his prize with the best. And MacLeod shared his prize with the Colip, who is physics head. He made the impurified insulin into a purified insulin. So that's how the side effects, allergic reactions, they all come down. Okay. So Banting at the age of 32 years, he got the Nobel Prize. So the youngest fellow is a Canadian, first Canadian to got the Nobel Prize is the Banting. Good. And before the discovery of the Banting, the discovery, diabetes means death sentence. They hardly live for about 6 months. Starvation wards unde. Before 1921, all the hospitals will have one ward. The ward name is starvation ward. To keep all the diabetics there. The treatment is starvation. So they may live for another 3 months or the 4 months or the 5 months. And finally they land up with infections, pneumonias, etc. because of the starvation, because of the deficiency of your protein, deficiency of your vitamins, etc. And then kicked off. So the mortality rate is guaranteed, 100% guaranteed in the starvation ward. All filled by diabetics. So that was the treatment. Now the game changer is the insulin therapy. Insulin therapy. Asal GDM is not there. In those days, without the insulin, all the GDM mothers used to die prematurely. Okay, is the holding without DMRDs range. Advantages: interfere with the inflammatory processes. They decrease the pain. They slow the disease progression. They retard the development of the joint erosions. They improve the functional disability. And finally, most important for all of us is quality of the life. So that also improves the quality of the life. That are the advantages of the DM. That is the reason all the DMRDs are very much useful in the management of the rheumatoid arthritis. So all these things are also there with your biologicals also. That actually alter the disease course. That is the disease modifying. Modifying means the alteration. They alter the disease course. Should be used as soon as the diagnosis is made. Don't wait further to start with the DMRDs. Appearance of the benefit delayed for the weeks to the months. So that is the time where you have to use the steroids for the bridge therapy. Nasciers must be continued with them until true remission is achieved. Induction of the true remission is unusual. So we don't know when the fellow is in the very much true remission. So these are the different DMRDs, the methotrexate, the gold standard, gold salts, cyclosporin, sulfasalazine, azathioprine. So these are all the important drugs. They are the immunosuppressive drugs. They reduce the inflammation of the rheumatoid arthritis, slows down the joint destruction, preserves the joint function. See the tablets, very small tablets. What is more important is the side effects. Dizziness, drowsiness, headache, pulmonary fibrosis, methotrexate lung, pneumonitis, anorexia, nausea, hepatotoxicity. So be careful in a chronic alcoholics and people with Hep B positive and Hep C positive, okay, and a known cirrhotics, etc. Stomatitis, infertility is a very common. It is more with the sulfasalazine therapy. So sulfasalazines will reduce the sperm size and also the sperm count. So the infertility individuals, infertility male with ankylosing spondylitis, ankylosing spondylitis also occurs in young individuals, more in the males. Again, the age group of 20 and 30 years or 40 years. So definitely in the history of the infertility, so definitely avoid using the sulfasalazine. Alopecia is very common with the methotrexate. Skin ulcerations, aplastic anemia, thrombocytopenia, leukopenia, nephropathy, fever, drug-induced fever. Drug-induced fever. Again, the DMRDs are very, very common. Photosensitivity. So we take some weeks to the months before they become the effective. So that is that point you have to tell twice or thrice to the patients. So whenever you see a new case of the rheumatoid arthritis on the day one, when I start the DMRDs, I told the patient that don't expect any response for a minimum 4 months. Sometimes I say for 6 months, don't expect any response. ఈ రోజు ఎలా ఉన్నావో 5 నెలల వరకు కూడా ఇలాగే ఉంటావు. నీ నొప్పులు ఏమీ తగ్గవు. ఇంకా ఎక్కువైనా ఎక్కువ అవ్వచ్చు. బట్ డోంట్ స్టాప్ ఇట్. బట్ 5 మంత్స్ తర్వాత 6 మంత్స్ తర్వాత సో డెఫినెట్గా చాలా బాగుంటుందంట అంటూ ఇక్కడ స్టెరాయిడ్ ఇచ్చేస్తాం. నెక్స్ట్ మంత్ వచ్చేటప్పటికే అబ్బాయి ఏం పెట్టారు డాక్టర్ గారు మీరు భలే ఉందండి మీరు 5 నెలలు అన్నారు అబద్ధాలు ఆడేస్తున్నారు తగ్గిపోయింది నాకు అండ్ దిస్ ఆల్ బికాస్ ఆఫ్ ద స్టెరాయిడ్స్ అండ్ స్లోలీ రెడ్యూస్ ద స్టెరాయిడ్ థెరపీ and keep on using the DMRDs and slowly the people will be very happy after 3 months or the 4 months or the 5th month. So these are the very important. You should be very careful in in educating the patient. The education is very, very important. So discuss the teratogenicity should be taken off drug several months prior to the conception. Discuss the body. This is again the pre-pregnancy counseling is very important because rheumatoid arthritis unfortunately is very common in young women. So definitely in the pre-pregnancy counseling when they are on the therapy this methotrexate etc so they are all phytotoxic so definitely they have to be stopped and the safest is the steroid and hydroxychloroquine. Suppose if the male counterpart is taking the sulfasalazine for some other reason maybe your ankylosing spondylitis that also should be stopped because that may cause for your infertility. So all these years, no, they blame the females for most of our infertility cases. But sometimes the male also play a major role as a causation of the infertility, especially sulfasalazine therapy. So these are the commonly drugs I told you, and the less commonly chloroquine. Now with the onset of the hydroxychloroquine, we are not using the chloroquine. So chloroquine causes more of gastritis and also retinal side effects, ophthalmic side effects. They are more with the chloroquine therapy, less with hydroxychloroquine. Gold, earlier we used to use the gold in the oral and also the parenteral form, but after the methotrexate and after the leflunomide, the gold therapy in the rheumatoid arthritis is almost like a history. Cyclosporin we often use sometimes. Dipenicillamine we are not using now. Minocycline, doxycycline, levamisole as an anti-inflammatory and immunomodulatory drugs. So that is the reason the doxycycline is very popular in our COVID era. Why? As a immunomodulatory drug. The same doxycycline can be used in the rheumatoid arthritis also. Suppose if you want to use some drugs, some antibiotic in a rheumatoid arthritis, then your first bet should be to watch this doxycycline because of its additional immunomodulatory effects. Azathioprine is a very important drug. Cyclophosphamide is very important. Chlorambucil rarely used. So out of these less commonly used, we use azathioprine, we use cyclophosphamide, we use doxycycline, we use cyclosporin. We don't use chloroquine or gold or dipenicillamine or chlorambucil. Hydroxychloroquine, it is available 200 milligrams, 300 milligrams, 400 milligrams, maybe twice a day, sometimes thrice a day, 3 months, then once daily. So usually we don't use 200 milligrams twice daily for 3 months, then once daily. So straight away you can use the twice daily for most of our patients. Then we will go for the 400 milligrams OD. If the compliance is poor, instead of the 200 milligrams BD, you can go up to the 400 milligrams OD also. Again, the side effects are very common with hydroxychloroquine. What are they? Pigmentation, skin pigmentation. So that can be seen in about 5 to 10% of the patients. Retinopathy, nausea, psychosis, and myopathies. Monitoring, fundus examination, and perimetry once in a year. So again, you have to write it on the case sheet. The patient is on the hydroxychloroquine. So advised ophthalmological evaluation at least once in a year. Once in a year. So onset of the action, not in the days or the hours. 2 to 4 months because this is a DMRD. Okay. Then the methotrexate. So 7.5 mg is available tablet, 10 mg is available, 12.5, 15, 20, 25. Again, not every day, once in a week. That is a very, very important. So either orally or intramuscular. We don't give subcutaneously methotrexate. We give either oral or injectable. Injectable means IM. Again, what are the side effects? Gastrointestinal upset, hepatotoxicity, bone marrow suppression, and pulmonary fibrosis. Okay, so that lung is called as the methotrexate lung. Sometimes it's very difficult to differentiate between interstitial lung disease caused by the rheumatoid arthritis or fibrosis caused by the methotrexate therapy. So the monitoring for all the DMRDs, we require complete blood picture. We require hepatic failure, hepatic parameters like SGPT, SGOT. We need the renal parameters like urea and creatinine. So these are the must. How often? At least once in 3 months. Okay. So once in 3 months, you get the complete blood picture, SGPT, SGOT, urea, creatinine when the fellows are on these DMRDs. Here onset of the action, 1 to 2 months. The peak action will be seen after 3 to 4 months of the methotrexate therapy. Sulfasalazine. It is like your like your metformin. Don't start metformin 15 mg or 2 grams once a day or twice a day on the day 1. You have to start with a low dose and then slowly up titrate. So the same thing happens to the sulfasalazine also. So start 500 milligrams OD for about 3 days or the 4 days or 1 week, and then 500 milligrams BD for the next 1 week, then the 500 milligrams TID, or then 1000 milligrams BD. That's how I start the sulfasalazine. I start 500 milligrams OD for first 1 week. Then 500 milligrams BD the next week. 500 milligrams TID the third week, and continue 500 milligrams TID if you are happy with the 1500 milligrams dosages. If you need 2 grams, so then you can make it as 1 gram BD on the 4th week. Leflunomide. So earlier we used to give the loading dose 100 milligrams, but now no loading dose, only 10 milligrams. This is the earlier one. Earlier loading dose of that leflunomide 100 milligrams daily for the 3 days, and then 10 to 20 milligrams daily. Nausea, diarrhea, alopecia, hepatotoxicity. So these are the very common side effects. LFT 6 to 8 weeks, and then onset of the action 1 to 2 months. So the monitoring, the same thing for all these things. How to monitoring tests, investigations, complete blood picture, SGPT, SGOT, urea creatinine. That's all. So the same things here, prescribing and the monitoring. So how the mechanism of the action? How the methotrexate acts? It is anti-metabolite, DNA synthesis inhibitor. That is the main action. So other things I discussed, the dosage, monitoring, main adverse effects, etc. See the leflunomide, where it acts, it inhibits the pyrimidine synthesis, DNA synthesis inhibitor. Like your methotrexate, DNA synthesis inhibitor. Both the DNA synthesis inhibitors are methotrexate and leflunomide. Methotrexate is an anti-metabolite, but here leflunomide, it inhibits the pyrimidine synthase. See the gold, etc., cyclosporins. Diagnostic tests for the rheumatoid arthritis. So the test: physical examination, rheumatoid factor, anti-CCP, ESR, X-ray examination, etc. DMRD therapy should be initiated as soon as the diagnosis of the rheumatoid arthritis is confirmed. There are now the robust data to show that early therapy with DMRD is critical for good long-term results. Lot of the studies are there. Undoubtedly now, early therapy with the DMRDs is very much critical for good long-term results. A delay of as little as 8 to 9 months in starting the DMRDs could impact the clinical outcome several years later. So that mistake you should not do as a physician. Okay? So the third one, see, read again, a delay of, read loudly. Last sentence you read. So as a good physician, we should not delay the management of the rheumatoid arthritis in prescribing your DMRDs. No wait and watch policy. Day 1, hit hard. Hit early, hit hard. So hit with DMRDs, hit with not with a single drug, at least with 2 to 3 drugs, DMRDs. Drugs used in the rheumatoid arthritis in the special situation. This is a very important slide. Pregnancy, among the DMRDs, sulfasalazine, hydroxychloroquine treatment be maintained. So don't use methotrexate and leflunomide in pregnancy. Lactation, steroids you can use. You can use the sulfasalazine with caution, and hydroxychloroquine you can use it. Okay. So you forget about sulfasalazine even in the lactation. Liver disease and alcoholics, hydroxychloroquine and gold are the safe. Again for the liver diseases and the alcoholics, so better to avoid the methotrexate and leflunomide. Here again hydroxychloroquine. Renal disease, paracetamol may be used in the lower strength. Hydroxychloroquine and sulfasalazine may be used. Lung disease, hydroxychloroquine, sulfasalazine and leflunomide can be used safely, but not the methotrexate. So in pregnancy, lactation, liver disease, renal disease, lung disease, the drug which is very much contraindicated is methotrexate. Whereas in the lung disease, you can use leflunomide in the place of the methotrexate. Whereas in all other conditions, leflunomide is also not needed. So in renal, in hepatic, pregnancy and lactation, methotrexate and leflunomides are contraindicated. Other drugs you can use, including the steroids. Biological response modifiers. Infliximab, excellent drug. Adalimumab, superb drug. Etanercept, that is also available. But my favorite drugs are infliximab and adalimumab. Earlier, each injection is available at the cost of 30,000 to 50,000. Now they are available at the cost of 5,000 to 8,000. Now a lot of the people are affordable to use adalimumab and infliximab. Not regularly, not daily. Maybe once in 15 days. Or maybe once in a week. Or once in a month. How long? Maybe lifelong. But tremendous response because they reduce the inflammation. They almost behave like the normal individuals. So, active rheumatoid arthritis, early rheumatoid arthritis, start with DMRDs and also aim for biologicals. If the patient can afford, tell on the day one, I tell to my patients, rheumatoid arthritis patients, see you have the two options. One is the DMRDs, another one is the biologicals. If you can afford, go for the biologicals. Earlier it was costing about 30 to 50,000. Now they are available at 5,000 to the 8,000 rupees. Not on the regular basis. Maybe once in 15 days or once in a month. You will get much bill. So meanwhile you can use the DMRDs. So a combination of the DMRDs and biologicals is much better. So earlier a lot of my patients are on the only DMRDs. At that time the biologicals costing is about 50,000 rupees. Now more than 50% of my patients, they are taking the biologicals also along with the DMRDs. So that is very, very important. So traditionally, cytokine antagonists are indicated in the treatment of the rheumatoid arthritis resistance. Resistant rheumatoid arthritis is defined as failure of response to at least 2 DMRDs used in optimal doses for an adequate period, at least 6 months. It is very, very rare, not that common, resistant rheumatoid arthritis. Okay, if you diagnose the rheumatoid arthritis, if you start with the 2 or the 3 rheumatoid arthritis DMRD drugs, and definitely they will get very good response. Even if they don't get the response after using these optimum dosages for about 6 months, then you can consider as the resistant rheumatoid arthritis, like your resistant hypertension. Define resistant hypertension: 3 antihypertensive medications at the maximum optimal dosages, no response. That means the blood pressure is still more than 140/90. That is resistant hypertension. Second definition, using 4 antihypertensive medications. Now the blood pressure is under control. Even then it is a resistant hypertension. We have the 2 definitions. One definition is 3 drugs, no response. That is the resistant hypertension. Second definition, 4 drugs, responded. That is also resistant hypertension. Good. Nearly 20 to 40% patients may not respond to the biologicals. See, here you have the synthetic DMRDs and the biological DMRDs. DMRDs are the biologicals, your infliximab, they are also DMRDs, but they are biologicals. So what your DMRDs like your leflunomide, rheumatoid, they are all the synthetic ones. So conventional and the targeted. I told you something about the methotrexate, hydroxychloroquine, sulfasalazine, but now the tofacitinib. So they are also available in the market. They are JAK inhibitors. Okay. So that is very much available in the market. Tofacitinib. So the tumor necrosis factor inhibitors like infliximab, adalimumab, golimumab, etanercept, they are all here. Interleukin 6 inhibitors, tocilizumab, and then B cell depletion, rituximab, abatacept, that is the T cell co-stimulation inhibitors. DMRDs are indicated in all patients with rheumatoid arthritis who continue to have the active disease even after 3 months of the NSAID uses. So don't expect the 3 months NSAID usage then use DA. That is a purposeful I keep this slide. So today's concept is don't wait for 3 months NSAID therapy, failure. So on the day 1, if diagnosis is rheumatoid arthritis, start DMRDs along with the NASCAR therapy. The period of 3 months is arbitrary and has been chosen since a small percentage of the patients may go into spontaneous remission. So don't bother about those small percentage of the people who got the spontaneous remission. That means a large number of the people, they don't get the spontaneous remission, and the 3 months period, your damage will be much higher. Okay, the risk versus the gain. The vast majority, however, need DMRDs, and many rheumatologists start DMRDs from, read loudly, last one. So start DMRDs from day, that is the take home point. How to select the DMRDs? There are no strict guidelines about which the DMRDs start first in an individual. Methotrexate has the rapid onset of the action than other DMRD. That is very important. So even today, all over the world, the number 1 DMRD to be started is always methotrexate. Okay, the number 1 anti-diabetic drug started all over the world is, both are letter M. Taking in account patient tolerance, cost considerations, and ease of once weekly oral administration, methotrexate is the DMRD of choice, most widely prescribed in the world and also most widely accepted by the patients. So that is their day of their choice. Some people on Wednesday, some people on Thursday, some people on Sunday, etc. Okay. Today patient comes to me, I start with the today only. Every Thursday you take 1 tablet. I don't want 1 day delay in using the DMRDs. So tomorrow I am going to see one rheumatoid arthritis new case, then DMRD methotrexate on every Friday. Okay, so that is how we have to start the DMRDs. Once in a week. Should DMRDs be used single or in combination? Since single DMRD therapy is often only modestly effective, combination therapy has an inherent appeal. So I have told you the slide also, 33% single drug, 2 drugs 44%, 3 drugs 75%, 76%. So DMRD combination is especially effective if you include methotrexate as an anchor drug. So this is a very important. What is the anchor drug? Methotrexate. Number 1 drug, methotrexate. Most potent drug, methotrexate. Most rapid acting DMRD, again methotrexate. So combination of methotrexate with leflunomide are synergistic since their mode of action is the different. So my favorite combination is the methotrexate and leflunomide. So leflunomide start with 10 milligrams OD. Earlier the loading dose of 100 milligrams for 3 days has gone. Now 10 milligrams every day or 20 milligrams every day. So I start with 10 milligrams for 1 month or 2 months. If the still I want much more response and the patient is not having any side effects and the CBP is the good, LFT is the good, or the renal profile is the good, then we may increase the dose of the leflunomide from 10 to the 20 milligrams. Limitations of the conventional DMRDs. The onset of the action takes several months. The remission induced in many cases is only partial. There may be substantial toxicity which requires the careful monitoring. DMRDs have a tendency to lose effectiveness with the time. So that is a very important practical point. So the slip out. So that means some resistance, like your aspirin resistance, your leptin resistance. What is leptin resistance? What is the leptin resistance? What is leptin? Hormone released from fat cell, adipocytes. Okay, adipocyte secretes leptin, adiponectin, resistin, interleukin 1, interleukin 6, tumor necrosis factor. So these are all the hormones released from the fat cell. Okay. Most important endocrine organ in the body. Most important endocrine organ in the body. Adipocytes. Not your pancreas. Okay, adipocytes. So now all over the world, now the adipocytes has gained lot of importance. Leptin is supposed to suppress the appetite. But all Indians are having more leptin. But still, we are more hungry. Am I right? Now, lot of people are dying because of overeating rather than the malnutrition. Earlier, all over the world, more deaths are due to malnutrition. But now India, not only India, all over the world, now the more deaths are due to overeating, obesity, rather than malnutrition. So we are having more leptin in our body. Leptin is supposed to suppress the appetite. But why we are taking more food? Because leptin resistance. We are having more and more leptin, but still leptin is not working at all. So because of obesity, the leptin is not working. Okay. Which is the good adiponectin? Sorry, which is the good hormone from the release from your fat cell? Lipoprofile, what is good? HDL. అలాగే ఫ్యాట్ సెల్స్ నుంచి కూడా వచ్చే పోయిందో చాలా చెప్పాను కదా A to Z చెప్పాను కదా అందులో వాట్ ఈస్ గుడ్ ఈజ్ adiponectin. All others are bad. Adiponectin is good, but unfortunately Indians are having low adiponectin levels. Unfortunately Indians are having low HDL levels. So because of the low HDL levels, because of the low adiponectin levels, we are at risk of getting the ischemic heart diseases much early. Okay, so for all these things, obesity is very important. So that is called leptin resistance. Bodies have a tendency to lose the effectiveness with the time slip out. These drawbacks have made the researchers look for alternative treatment strategies for RA, that is the biological response method, biologicals. Why biologicals enter into the market? Because of this DMRD's slipping out action. So immunosuppressive therapy, azathioprine, cyclophosphamide, cyclosporine. So these are the dosages. See, already told you the dose of the azathioprine. 50 milligrams is available tablet. 25 mg is also available. So 25 mg BD, it will make as 50 mg, or 50 mg BD, 100 milligrams. Usually we use up to 100 milligrams only azathioprine. What are the side effects? Gastrointestinal side effects, myelosuppression, and more chances of having infections. Cyclosporine. Cyclosporine where? What is the common indication to use cyclosporine? Renal transplantation. Post-renal transplantation. So most of the people, they are on cyclosporine. Cyclosporine causes diabetes or hypertension? Good, hypertension. Cyclosporine increases the blood pressures. Cyclophosphamide. So here it is 3 to 5 milligrams per kg per day. And nephrotoxic, hypertension, hyperkalemia. Okay. Then cyclophosphamide. Cyclophosphamide 50 to 150 milligrams. So myelosuppression, gonadal toxicity, hemorrhagic cystitis. So that is a very common cyclophosphamide. Okay. And bladder cancer. Monitoring the treatment with the DMRDs. These drugs need the frequent monitoring. So blood, your CBP, your liver, SGPT, SGOT, your lung, sometimes when the fellow is having the dyspnea, etc., maybe CT lung, and the kidney, urea creatinine. They are the frequent sites of the adverse effects. So every 3 months we get the CBP, we get the SGPT, SGOT, urea creatinine, but we don't get the CT lungs every once in 3 months. So when the fellow is complaining of the breathlessness and there is hypoxic conditions, and definitely get the CT chest to rule out any interstitial lung disease or methotrexate lung. Interval of the laboratory testing varies with the drug. 4 to 8 week intervals are commonly needed, but usually you would go for 12 to 16 weeks. Most patients need to be seen 3 to 6 months, 3 to 6 times a year, but Indians it is not possible. So usually I see maybe 2 to 3 times a year. Maybe once in 3 months or once in 4 months. Some people maybe once in 6 months. So this is a very good slide. Shows you the adverse effects of the DMRDs. See the hydroxychloroquine. So these are the common side effect profile. That's how we have to go for the monitoring. So by getting your CBP, your SGPT, SGOT, and also your urea creatinine, so you can rule out the hematological or lung liver and the renal side effects. So these are the targets of the activities: hydroxychloroquine, T lymphocytes, leflunomide, already told you the pyrimidine synthesis, methotrexate, dihydrofolate reductase and folate metabolism. So you have to supplement the folic acid whenever the fellow is on the methotrexate. That is a very important point. So I tell my patient to take the methotrexate once in a week and folic acid 5 milligrams twice in a week, at least twice in a week. Sometimes some people they write 5 days in a week, some people every day. I prefer only twice a day. Okay. So sulfasalazine. So the multifactorial including impairment of the lymphocyte function and the cytokine synthesis. They need the frequent monitoring once in 3 months or once in 4 months or once in 6 months. So these are the important drugs: etanercept, adalimumab, infliximab, etc. They used in the management of the inflammatory conditions, not only rheumatoid arthritis, we use it in ulcerative colitis, we use it in the Crohn's disease, and we use it in the autoimmune encephalitis, so etc. So the NSAIDs may be the contraindicated, promptly improve the symptoms of the rheumatoid arthritis. They are very good drugs, responds very well, and the people will be very happy with the biological therapy. So what are the side effects? Increased appetite like your steroid, weight gain, water and salt retention, increased blood pressure, thinning of the skin, depression, mood swings, muscle weakness, osteoporosis, delayed wound healing, onset and the worsening of the disease. Almost like your steroid side effects can be seen with these drugs. Take the medicines as diet, encourage the food diet, discuss the body image and discuss the risk for the infection. So one thing is very clear that before starting these biologicals, your rituximab or infliximab or adalimumab, 3 tests are very must. One is Manto, the second one is quantiferon gold, and the third one is CT chest to rule out latent tuberculosis. So without doing these tests, if you start using these biologicals, if the fellow happens to be in the latent Cox phase, so the disease will be very active. So that is very important. So always, even though the patient is interested to take the biologicals on the day 1, I don't write on the day 1. I write only these 3 tests. Manto to be done, read after 48 hours. Set the blood for your quantiferon gold. It may take maybe 2 to 3 days. And CT chest, maybe in 1 day or 1 day we'll get the CT chest. So after 3 days or the 4th days, so come with the reports. All the reports are the negative. Then start using the biologicals. This is a very important take home point. So these are all the antigens, CD4 T cells. Already this slide showed you last week. So the beta cell activation, macrophage activation, and then the endothelial activations. Finally the Fanus formation. So the Fanus, I showed you the picture of your synovial membrane destruction, etc., and new bone formation, etc. So these are all the pathophysiological ways of causing these endothelial activation, macrophage activation, beta cell activation caused by these things. Cytokines, they are the key mediators of the immune function, have been the major targets of the therapeutic manipulations. Of the various cytokines, tumor necrosis factor alpha has attracted the maximum attention. So we have the different drugs in anti-tumor necrosis factor agents like infliximab, etanercept, adalimumab. They are very popular. And the second drug is probably the rituximab, that is the anti-CD2, CD20 antibodies. See the infliximab, the dose 3 milligrams of per kg IV infusion at weeks 0. And second injection is given after 15 days, at 2 weeks. And third injection is given 6 months. So this is all very, very important, followed by the maintenance dose every 8 weeks. So once in 2 months, we give it as to be combined with the methotrexate. So keep using the methotrexate, keep using the steroids, or keep using the NSAIDs, even though the patient is on the biologicals. So after few months, so this patient will be so good, and then you can stop using these NSAIDs and the steroids and etc. and start using, continue the methotrexate and take this infliximab or rituximab or adalimumab maybe once in 2 months or once in 3 months. You take 1 shot. So the mild disease. So now this is the very important take home points. Mild disease. Meet the ACR criteria for rheumatoid arthritis and have some of the following clinical features like arthritis, arthralgia, 3 inflamed or swollen joints, no extra-articular disease, a negative or positive rheumatoid factor test. That is very important. Don't expect the rheumatoid factor positivity in all the cases of rheumatoid arthritis. Maybe positive 80 to 85% of the cases. That means 10 to 15% of the cases they are still rheumatoid arthritis, but your RA factor will be the negative. That means RA factor negative rheumatoid arthritis. Okay, seronegative rheumatoid arthritis. Elevated ESR, CRP concentrations, no evidence of erosions or cartilage loss on the plain X-rays. So my appeal to all of you is you have to diagnose the rheumatoid arthritis at this stage only. At this stage only. Anyone can diagnose in the moderate and the severe. Here see the patient presents with arthralgia. How many joints are there? 3 inflamed joints. Any extra-articular disease? No. Positivity is always present in 100%? No. 15% may be negative. Is there any elevated ESR or CRP? Usually yes. Any X-ray shows any erosions or MRI shows any erosions? No. So that means you have to diagnose the rheumatoid arthritis in the absence of extra-articular nodules, okay, extra-articular features or rheumatoid nodules or negative marker and also negative radiological manifestations. So here only positive is history, some arthralgia, some symptoms or signs of the joints, maybe 3 or the 4 joints bilaterally, and maybe elevation of your ESR and the CRP. At this juncture, even though the RA factor is negative, if you diagnose the rheumatoid arthritis, you are doing a lot of justice to the patient not to go into the moderate or the severe or the disabilities. So moderate disease, I think anyone can diagnose here. See, between 6 and 20 inflamed joints, 6 to 20 inflamed joints. Absence of the extra-articular disease most commonly. Elevations of ESR, CRP may be 80, 90, 100. Positive rheumatoid factors, positive anti-CCP antibodies, and evidence of inflammation via plain X-rays. So even X-ray will show the bony erosions. So X-ray report is mostly inflammatory arthritis. Okay, so then anyone diagnose. So again the treatment is only DMRD, steroids, biologicals, etc. Severe disease. See, even today we see a lot of the cases. Severe disease, how are they? More than 20 inflamed joints. Rapid decline in the functional capacity. Usually the wheelchairs, they used to come into our chambers and wheelchairs only. The disease is very aggressive. More joints are involved. ESR will be 110, 120, 130. CRP will be 40, 80, 100. And hemoglobin is 6, 7, 8, maybe 4.5, 5. Hypoalbuminemia. So the total proteins are 6. Albumin is 2.3. Globulin is 4.5. Reversal albumin globulin ratio. A positive factors, very high titers. Anti-CCP, rheumatoid factor, they are very positive, and X-ray shows rapid progression and also destruction of the joints, and also have extra-articular disease like interstitial lung disease or hepatitis or renal, etc. etc. So this is the very severe disease. So should not allow our patients to reach this stage of the severe rheumatoid arthritis by properly diagnosing even at the here only. If you diagnose here, ikkada miss aithe, ఇక్కడ అస్సలు మిస్ అవ్వకూడదు, ఇక్కడ రాకూడదు. ఓకే, ఇక్కడికి వస్తే మనం ఏం చేయలేం. వెరీ లిటిల్ కెన్ బి డన్ బికాజ్ ఆల్రెడీ వీల్ చైల్డ్. సో మేనేజ్మెంట్ based upon the patient's physical assessment, etc., severity, physical activity, challenging. Management continues. Patient education is very important. Counseling is very important. Rest, exercise, physical therapy, occupational therapy, good nutrition diet, good fiber diet, etc. Bone protection with your calcium, with your vitamin D3. So vitamin D3 60,000 once in a week for about 8 to 12 weeks, then once in a month, lifelong. Combination therapy. Drug toxicity, how to monitor, you know that. End stage of the disease, goals of the therapy, pain relief, protection of the remaining articular structures, maintenance of the function. Non-pharmaceutical interventions are particularly important here. Some yoga, some meditation, some chai, some acupuncture, herbal medicines, Ayurveda, Unani, etc. and etc. Indications for surgical interventions: intractable pain, severe functional disability due to the joint destruction, go for the replacement therapies, tendon ruptures. Timing of the surgery is often critical. So treatment of the monitoring, already I told you. The goal of rheumatoid arthritis treatment is no longer to simplify, control the symptoms, but to eradicate the inflammation. You read it. What is your goal? No longer simply control the symptoms, but to eradicate the inflammation. That is very important. So the target of DMRD therapy is no signs of active inflammation, no swollen joints, normal ESR, little or no radiographic progression. At that juncture only you have to see it. That is the remission. Although remission is the target, minimal disease activity may be an acceptable alternative. When remission is not possible, especially the established long-standing disease, or when comorbidities or other patient factors limit DMRD options. How to monitor the treatment in the rheumatoid arthritis? So this is the DAS activity. DAS 28 means disease activity score. That includes tender joint count, swollen joint count, ESR, and patient global disease activity assessment. So it will take just half minute to 1 hour when you are busy. So see the tender joints, see the swollen joints, see the ESR, and then has a global patient global level. So you consider them as the moderate, severe and high. Suppose if the score is less than 3.2, it is a low, 3.2 to 5.1 is the moderate, and more than 5.1 is the high. So the disease activity. When it is very more than 5.1, we have to use the combination drug therapies, biologicals, etc. So this is the diagrammatic significance. A change of 1.2 in DAS 26 is considered a meaningful change. With the scores, how long should treatment be continued? Once remission is achieved, the maintenance dose for a long period is recommended. Once the remission is achieved, don't stop the drugs. Even don't stop the DMRDs also. Even you have to use just 5 milligrams or 7.5 milligrams methotrexate lifelong. So that is the maintenance dose. Relapse occurs in 3 to 5 months. 1 to 2 months in the case of the methotrexate if drug is discontinued in the most instances. Again the relapse occurs. So whatever you say, most of our patients, they don't listen our words. When they are asymptomatic, they thought that I have to stop the drugs because I am asymptomatic. Why should I take the drugs? Then the relapse will occur. Again in the relapse, they come to us. DMRDs are discontinued by the patients because of the toxicity or the secondary failure, and such patients might have to shift other different DMRDs over 5 to 10 years. Disease flare may require the escalation of the DMRD dose with a short course of the steroids. Suppose earlier the patient used to take that 15 milligrams of methotrexate. She got the remission. Again present with the relapse. Then you have to increase the dose of the methotrexate from 15 milligrams to the 20 milligrams. This is a very important take-home point. Don't start with again 15 milligrams and stay to the 15. That means if you are starting with the 15 milligrams, again the patient will get the relapse, again the recurrence. So I stop here. So I hope I have given you a bird's overview of the management of rheumatoid arthritis. So this is the very important. I have the 3 cases to discuss. So because of the paucity of the time, this is the case 1 and case 2. See the erosions, see the methotrexate. DMRDs have a dark side. Methotrexate may cause serious problems. Lung, liver, bone marrow. So be on the lookout for toxicity with all the DMRDs. Methotrexate lung, dry cough, shortness of the breath, fever, most often seen in the first 6 months of the methotrexate treatment. Diffuse interstitial pattern of the X-ray. Bronchoalveolar lavage may be needed to rule out the infection also. Acute mortality, 17%. 50 to 60% recur with the treatment, which carries the same mortality. Risk factors who get the methotrexate lung: elderly, rheumatoid arthritis lung, prior use of the DMRDs, low albumin, and diabetic individuals. With this I stop. Thank you very much. I think okay. What is this slide? Surgery for rheumatoid arthritis. It makes a creaking, popping sound every time I go in or out. that is just your knees, sir. Okay, when he is sitting on the chair, so knee flexion and knee extension is getting sounds. So fit for surgery. So there is a time to go for knee replacement. Surgical approaches. So take home message, commonest inflammatory joint disease seen in the clinical practice affecting the approximately 1% of the population. Female to male ratio, not 3:1, maybe in our Godavari districts, maybe 10:1, 20:1. Small joints of the hand and the feet are typically involved. A score of more than 6/10 is needed for classification of the patient having definite rheumatoid arthritis. Treatment should be started early and should be individualized. Conventional DMRDs are useful first in the rheumatoid arthritis. If inadequate response to the conventional, then the biologicals are used, or you can start with the biologicals also. That's not hard and fast rule that you should start with the DMRDs and biologicals are the next. The most preferred biologicals are the tumor necrosis factor inhibitors like your adalimumab and infliximab. So thank you very much.